I think telemedicine 7 weeks ago, pre-COVID was like where people were before internet shopping happened.
You're on the forefront of telemedicine, so you knew about this for years. We're all now finally opening our eyes to it. You're in Virginia, right? Virginia Beach?
I'm in Virginia, yeah, Virginia Beach, so kind of southeast Virginia. So I'm actually working as a contractor for the Navy right now. So
Awesome.
which is a really, I think, really, it's an awesome job. I mean, to be honest, it's an awesome job. And so I work with predominantly like active duty sailors. So like the guys who went to the Comfort, who went up to New York on the Comfort. Those are all my colleagues that were on the ship there.
Okay.
So
Wow.
but then also on the flip side, a lot of the patients that got sick on the Roosevelt, those are also my patients. So, or excuse me, sailors that were on the Roosevelt. Those are the people that I see. So like the ships will come in, and basically the sailors live on the ship, and then they would just walk to my clinic.
Wow. All right.
So
I mean, yeah. So because obviously COVID-19 is affecting everyone, across the
yeah,
nation.
yeah,
But how's it been for you over there in Virginia? But besides, I know you take care of a lot of this military personnel, but
sure.
overall, how's the sort of COVID-19 experience been?
Um, it's been I've been lucky. I guess that's what I would say, because the caseload here hasn't been that high. It's maybe in the hundreds and maybe like less than 100 deaths in this area.
Okay.
That might be maybe even less than 50, to be honest. Virginia in general is like, nowhere like the Northeast right now. So it hasn't been too bad. 'Cause I haven't seen I haven't seen a patient in clinic for just over a month now.
Right.
So I've been doing predominantly telemedicine for the Navy. But my telemedicine experience prior to this obviously made it a lot easier. But
So let's kind of get into that. I mean, and likewise, I'll just say that similarly with us, right? We haven't really been seeing patients in the office. We're trying to keep healthy patients, meaning patients that don't have COVID. We're trying to keep them out of the hospital, and so we've all been sort of trying to ramp up telemedicine over the past month and a half. And
yeah,
we're not the only hospital. Obviously, there's so many different institutions and even private practices trying to ramp up telemedicine. And I always dubbed you sort of as the
yeah,
telemedicine guru because
I
you've been
appreciate
doing
it.
it for years, right?
Yeah, I started this my business in about 2017, 18. I started brainstorming about it actually probably closer to 2016. And then I finally kind of made it a LLC, kind of, a formal tax structure in about 2018. When I was in private practice, I used to email patients a lot using our patient portal. So that's actually kind of how I started, was just emailing. And the my private practice I was in was like, I was super full. So obviously, like, are you in kind of academics, or pseudo, or not pseudo, but half and half academics, private portal, or
Sure.
private practice?
I was in private practice for 3 years,
Yeah,
and then I moved over to academics. So I've been in academics now
yeah,
for probably about 4 years, 4 or 5 years. But yeah, right. I'm in academics now. I mean, it's sort of a private practice model in the sense that we're trying to build it like a private practice,
sure,
but it's
sure.
we very much have residents and fellows that we teach, and it's the academic setting.
Right, 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 right. Yeah. So I kind of started it with, I mean, you were in private practice, so like, access is like the big thing, the big metric that the practice really kind of cares about, and from a business standpoint, as I should. And so one of the problems I ran into was, I was like 8, 10, 12 weeks out, which is, a good problem to have if you're productivity based, right?
Right.
But obviously, that's not great for patient care. So what I started to do was, we had a patient portal that I would just basically email patients just to kind of check in with them, or to see how they're doing. And of course we get all these questions like post injection questions, and my staff would get the message, they would write it down, then they would put a piece of paper on my desk, and then I would have to, it was this whole workflow thing. And I was like, just have them email me, because like to get on a call, as you know, is like, it's very disruptive to the workflow, people would start to email me. I was like, oh, okay, it wasn't too bad, and it was very efficient. So I was like, oh wow, this is actually working pretty well. The practice was okay with it, obviously, because it was, HIPAA compliant and so on and so forth. But I kind of brought it up as like, hey, like, what do you guys think about this? And of course, docs are like, no, don't open the floodgates, because we don't want to get
Yeah.
inundated with more emails, more clicks, and this and that. But I actually did a PIP on it, a project improvement. So I actually tracked my access time. So I didn't do it intentionally. I was kind of just very neurotic about access, about certain clinics, and why certain clinics better than others.
Right.
So I kind of did an academy project for it for MOC, and I was able to shrink my weight down from about 8 to 10 weeks down to less than 14 days. Yeah. And what I was doing was like, I mean, because you do interventional spine, right? So
Right.
at least part of your practice, right? So I was that was pretty much my role there as well. And I would do an injection, and then I would see people back 2 weeks later. You know, did it work? Did it not work?
Right.
And I was kind of like, these were like really like 2 to 5 minute conversations on the whole. And while they are valuable, it wasn't really a good use of my time or the patient's time. So what I started to do was like, I would just email them and say, hey, did it work? And they would say yes. And then I would just say, great, see me back in about 6 to 8 weeks. When it with a real test of it, right?
Right.
That. So I would use the email as a way to kind of check in with them, and then say, she's doing really well, or I'm not doing really well at all. Let's get further imaging, or let's do
Right.
this. Let's have you restart therapy, or let's have you see the surgeon. That kind of thing. So that's kind of, I know it's kind of a long answer. I probably kind
No,
of
no,
jumped a lot of stuff.
that's great though. I mean, I think our experience is definitely parallel, right? And I'm sure
Yeah.
they do for many people in our field, right? We do certain procedures on patients, whether it's joint or spine or anything of that sort. We have them come back in 2 weeks, right, for a checkup, and right, those patients that come back and they feel great, I'm happy they feel great, but then I feel a little bit guilty of I brought you back to the to the hospital for a visit, only for you to tell me that you feel great. Like
Right.
we could have been way more efficient with this.
Right.
That being
Right.
said, those patients that don't feel great, it is nice to see them back in the hospital, or back in the
Yep.
office, so that you can re-examine them, see if you missed something, maybe order some more testing. And that I do like the in-person contact, but I agree. I've noticed over the past couple of years, there are a lot of visits that are simply so quick that I just feel like, this could have been done much more efficiently through other means. But yeah, I mean, because we've now all been forced to do telemedicine due to
Hmm.
this stay-at-home orders, the quarantine, keeping people safe away from the hospital, and I see the benefit of telemedicine, of course, and I definitely foresee a hybrid in the future for us. You've probably already been doing it, but for us, I see us still seeing some patients in the hospital or in the office if they need to be seen in the office, if they're severe enough. But then for simple things like a checkup after a procedure, or even going over imaging with the patient,
Right.
setting up actual dedicated time for telemedicine, wonderful. Because like you said, yeah, there's time that's eaten up when the patient gets checked in, gets their blood pressure checked, their heart rate, gets all their vitals, gets roomed. There's all that time that gets eaten up to do all that. When at 2:30, I can just call up Mr. Smith and just say, get him right on the phone and say, all right, here it is. Let's get right to it. Here's what your MRI shows. And what I find is when I've blocked enough time for that, I'm able to not just go over their MRI, but I'm able to get into sort of like sometimes deeper conversations with them about their health in general, because
Hmm.
there's no pressure for me to have to get out of a room and get into the next room because the next person's waiting. I have a lot
Absolutely.
more time.
I think telemedicine 7 weeks ago, pre-COVID, was like where people were before internet shopping happened.
Sure.
I mean, I
Yeah.
think that honestly, that's where I think telemedicine, it's what it's been waiting for, because insurance companies, they have codes for this stuff. They've always had these codes, but they just wouldn't pay for it. You know what I mean? So
Right. That's one of the things hurdles that we had to jump through when we first getting this thing started. I mean,
right,
rather quick because of the outbreak. But
Right. So the way I kind of viewed telemedicine, even before my own business, was really to not just provide access, but open up other opportunities. So what I noticed when I shrunk down my clinic wait time from 8 weeks to down to less than 2 weeks was that it allowed more opportunity for new patient visits, like face to face. I was like, okay, maybe let me see how this model works. Like if I just try and focus my face to faces for new patients and maybe procedures, and then leave everything else to the side. That's kind of how everything kind of started. But what was interesting was like I was able to shrink everything down, but then there's kind of this paradox in a big, very, very busy private practice group, and maybe even just across. I think there've been like behavioral economists have kind of noticed this, where I was so available that I would actually my no-show rate actually increased.
wow.
Basically, like, or people will value what is hard to obtain. So I would notice that people would call like Monday morning for a 2:30 appointment, and like, oh, awesome, and then they would no show because in a way I have nothing. This is all just speculation, but it's like versus the people that waited 8 weeks, they're like, I got to make it,
Right.
because
That's interesting, man. It goes into a little bit of psychology. You're right,
yeah,
and we've noticed that a little bit in the sense that before we started implementing telemedicine, some of our admins were saying, "Well, this would be a great thing because they say that the no-show rate for telemedicine is virtually zero, or is much less than what you would get in the office. We get some no-shows in the office, of course." But I'm sure, if we have less no shows, that's better. I'd love to sort of have a more predictable schedule. But we have found, because we've opened the floodgates in the sense that we've opened up our whole clinic schedule for a whole bunch of telemedicine, we gave a whole bunch of available times. We do get no shows. And these are also sometimes visits that we have secured the day before or 2 days before. So, you kind of think to yourself, well, how do you forget? You can't forget. We
right,
just talked about this yesterday.
right.
How did you forget? So, but I'm wondering if that is what you're saying. Is it's psychology in a way. When something is readily available, you tend to maybe take it for granted.
Convenience is sometimes too is not always valued. It
Yeah.
is, but it isn't. It's a very interesting experience because it's like in some ways it's just that much more easier, but it can be sometimes just as dispensable. So
So in keeping with that, since you've probably gone through so many errors and successes over the past couple of years with telemedicine, we've all just started this. Like, do you have any tips or any experiences that you encountered over the years that you've learned from that maybe we can learn from to make?
sure, I would say probably just as you guys are probably starting to get comfortable with the camera, is like record yourself. If you haven't, like, actually see what you look like on camera in terms of like how you're talking. Like I try, even now I sometimes struggle to kind of where are my eyes, kind of a thing.
Sure.
um in practice, I'm not awesome at it. I'm better than where I was. That's probably tip number one. Lighting. Lighting is a big issue.
Right.
Whatever you can control, because you are still trying to be professional as much as you can. So as much as you can control your environment, that's probably, and I think lighting makes a big issue, or is a big issue. Like where my home office is, it's not ideal. So I bought like a separate light, and I've tried to kind of work in different spaces to try and make things look clean.
Yeah, you have great lighting right now.
Yeah,
It
yeah,
seems
yeah. So
very
yeah, I
good.
have like one. Yeah, I have one of those like selfie light basically, and it makes a big difference, because like what I used to have to do is you'd have to like kind of touch the screen to kind of like, make it look whatever. But the other thing I would say, the height of the camera. Um, that is, I think, really, again, goes along the professionalism thing part of things. Is when I first started, I was like using like an iPad, and it would be, laying down, or sometimes it wasn't at the right angle. So I invested in at least like a tripod or something where it was like face to face.
Sure.
Which what you'll notice, as if I'm sure you've done some telemedicine where, you'll the patient you're talking to will have it angled, so you're basically looking up at their nose.
Yeah, yeah,
Um,
it's wonderful.
and again, it's not, not super professional. So I would say from a visual standpoint, that's probably the the, the three things from an advice standpoint. Yeah, I was gonna say, like, clinically in my workflow, I have the patients kind of upload all of their documents as best as they can, so I can at least do a chart review, just so I can again kind of maximize our time.
Sure.
Um, that's something that took a little finagling. It's a little bit easier with EMRs, but imaging is still a challenge. I'll say that. So that's one thing I'm still kind of working on. If you have access to like local centers, or if that's probably less of an issue. But some every night, a lot of my patients are like kind of second consults. So they're like, well, I got a CV. How do I work around this? And sometimes I just like, well, just give me the report and we can try and work from there, that sort of thing.
Right.
So just being prepared in terms of like making sure that they have everything, because I think also one of the things I noticed with the patients is that they kind of assume that you kind of have everything still. Like in a way, like it's like we're so tech savvy that like that information is like universal.
Right.
And there's kind of still that assumption. And I think the fact, like, even in face-to-face encounters, but because it's virtual, it's like somehow heightened in their mind that we have everything.
I
And
know.
so it's, be as prepared as you can. I try to prepare the patients. I'll shoot them an email or a text message or something like, hey, we're about to get on a call. Did you do everything you're supposed to do? um
That's helpful, actually.
yeah.
Yeah.
The physical exam stuff, I'm not sure if you went on my YouTube, but basically it's hard to do. Physical exam is obviously hard to do, and it's one of the big, obviously, like, limiting factors. I think telemedicine is awesome for like derm, things like that, where it's,
Or even like
you can take a
psychology
picture. I think,
services, and like,
yeah, psychology, exactly. But for anything that's, pain, ortho, that sort of stuff, it's, we're very reliant on our physical exam.
right.
What I started to do is that I would send them videos or direct them to, I now post it on my YouTube. I basically sent them videos of things that I wanted them to do. Simple stuff like crossing their legs. Let me see you touch your toes this way. Like, I won't say it's a Sperling test, but I'll say, can you just look up and do this? That way I would just kind of rely on their reporting ability. So there's definitely limitations. Yeah.
Yeah, we've been sort of similarly. We've been just asking them to just show us a little bit of range of motion,
Yeah.
and if it's maybe their walking pattern or something of that sort. Yeah, so it is limited, but I agree. There are some things you can have them do to gain some idea.
Yeah.
Do you ever have them prompt them to set up their telemedicine visit in a room or an area where they can maybe step back and you can see the whole body or something like that?
Yeah. It's kind of hit or miss. You know what I mean? Like, it's hit or miss. Some people are pretty, are ready to do it, but it's hard.
It's hard.
I think.
I want.
Yeah. I mean,
I
it's not hard, but it's like, it ends up being not helpful in a way.
Right. But I'm optimistic because I think that because of this, because of everything we're going through right now, and that now telemedicine is for sure going to be part of our lives, so everyone's lives. I think that maybe teaching the patient on how to engage in it, how to have a proper telemedicine visit, at least for our purposes, I think it's going to be more. It's going to be easier, I think, to coach
I
them.
agree. I
Um,
agree.
Especially if
I
you have,
agree.
I haven't seen your YouTube videos, but I will definitely check them out. But especially if you have some YouTube content on, like, here's what you can do at home to help make this go smoother. And so teaching the
Yeah.
patient how to be, and if you don't have that, please do it, because that would be great.
I guess.
Um,
Right.
and I guess, yeah, I mean, like, so where do you see all of this now going forward? Obviously, the COVID-19 numbers are slowing down a little bit. There's always this fear of a second wave. There's always this fear of just reinfection rates, once we open up our communities, which is happening right
Sure.
now.
Sure.
How do you see medicine changing?
One of the common questions everyone's asking is like, is it here to stay? That's kind of the big question. I think so. That being said, my concern with it, and again, I'm getting a little bit into this is purely my opinion, is I think that telemedicine has very high abuse potential.
Okay.
Um, in terms of like, it's just too much. I'm worried about potential litigation things that will pop up and somehow blame telemedicine. That being said, you, we'll just have to kind of see. But I'm optimistic on the flip side. On the whole, I'm optimistic. The parity in pay is interesting, because the parity in pay meaning like, one of the big issues with telemedicine was like they just weren't paying the same as a follow up or as a new patient.
Right.
That was actually on the way up. Like parity laws were starting to come into play pre-COVID, like weeks, months, and now they're paying the same. So my concern in the insurance model is if they start to see an uptick or they're paying too much or they see a hit to their bottom line, is like how are they going to rein that in? Like
Right.
um like you, not sure if you do EMGs, but you well know how that got handled.
Yeah.
you know right.
So essentially, the more we use something, because for whatever reason, the more likely it's going to get cut by the rates for reimbursement are going to get cut, which is unfortunate, of
Yeah.
course,
Yeah.
in many ways, because there's things that we do that are so helpful for patients. And when you train more people to do them well and you start doing them more and more and more, and then all of a sudden the value of what you do goes down. It's a
Yeah.
shame. Yeah, no,
Yeah.
I agree. With on a concept of litigation, maybe there needs to be a group of people that just kind of gets together, put together some sort of, even unofficial document on just what can you expect from telemedicine, what's appropriate, what are the limitations, just putting everything out there. We try to do that with our patient visits now. We don't have any script, and we probably should, but we just try to tell the patients like, listen, this is not ideal right now. We're doing this to keep you safe. We know that there's limitations to what we're doing. We're just trying to check in with you, see how you're doing, continue your care so there's no real blip.
Sure.
But we
Sure.
realize there's limitations. We can't really examine you. So, everything we say, we got to kind of hold that with a grain of salt in a way, but maybe in more of an official way, there needs to be some sort of document or some attestation or something.
Yeah.
Um,
To kind of get back to one of the tips also, not every patient is made for telemedicine.
right.
I remember distinctly having a couple patients, set up an appointment, and I just flatly told them like, you need to be seen in person. And it wasn't necessarily because it was something like emergent. It was just like that one patient was like, what it sounded like a true ridic, and I was like, like sounded like they're actually weak. That one is kind of an easy punt.
Right.
But the one patient I have in mind was just not a great historian.
Yes.
Just really just, maybe it was camera shy, maybe they're nervous, but the history was just, I couldn't get it straight. And I kind of told him, I was like, I think that it's best if you're seen in person by someone local. So I think as people start to get excited about using telemedicine, they will reach one of those patients where they're like, oh, probably not the best medium, at least maybe not for this visit.
I agree. It's funny that our follow up, since it's only been a month and a half, so we've engaged in a lot of follow up visits using telemedicine, and it's gone rather smoothly. But I find new patients to be challenging right now,
Yeah.
just because I don't know them as well, and sometimes the technology, everyone's got different camera quality, everyone has different everything, devices, and so sometimes the quality isn't great. Sometimes there is a language barrier, unfortunately. Sometimes there is just all these different barriers. And that, yeah, at the end of the visit, when I feel like, God, I didn't get a good picture of what that was, I have to ask him, listen, I know we just spent the last half an hour trying to hash this through, but I really need you to come in. I'm just saying, I
Yeah.
think you need to come in and we need to kind of do this again because
Yeah.
I wasn't able to get a good picture here.
Yeah. So my right now with what I'm doing, kind of the same thing. Like I have new patients scheduled. I'm using the telemedicine to kind of gauge whether or not imaging is appropriate. So that's one thing I have been doing is that, while we love for for patients to have had all conservative management before getting imaging, I would hate for one of my patients to wait all the time for me to come in for me to only tell them, well, we need to get an MRI. So
Yeah.
that's one of the things I'm kind of curious in the future to see if insurance companies are going to pay for that. Is that enough, like a telemedicine visit to get an MRI, that kind of stuff? Because in some ways, I think that there is value of sometimes you just need to have imaging, and
Right.
every now and then you get, and you hear the patients get frustrated. They're like, well, why didn't they just get the MRI before? And while conservative management is important, sometimes you're like, yeah, I wish I kind of did have one because now they got to
Yeah.
wait another 8 weeks to get a follow-up appointment with me. But
Well, it's one of those things where exactly no, I mean two scenarios I can think of. I've had a couple patients where I've sent them to physical therapy and I've sent them to conservative management. We've examined them in the office and we knew that this has to be a disc herniation, even though there wasn't weakness, there wasn't overt weakness, right?
sure,
But that radiating pain pattern, I was like, this has to be a disc herniation. And
right,
oftentimes the therapist, physical therapists, they want to know what the diagnosis is like exactly, so they won't do something that's going to hurt the patient more.
right,
And they ask for an MRI, and I say I can order one, and then I have to get into this little discussion with an insurance company on why I'm ordering an MRI before physical therapy. And it literally to the point where I was like, I think I'm clear on this diagnosis. I think I know what's happening, but we want to know for sure because the therapist is going to modify what their exercise routine will
hmm
be based on that imaging, and that's why we're ordering it. But we have to go through that step of convincing the
yep,
insurance company to allow us to do that. Likewise, like what you said, there are many times where I've for new patients, even if they're coming into the office, I would just call them beforehand just to check in and just say, happy to see you next week. I just want to come check in and see if everything is okay, et cetera. And they tell me their story. And from their story, I can tell, wow, you really probably need imaging, and,
right, right, right,
and yeah, we run into that problem of, well, I can order it for you now, but there's a chance it's going to get denied because we haven't had an official visit. So, and then they're asking me, well, do I need to come in for an official visit just so you can order an MRI? I'm like, yes, I
yeah,
wish it wasn't the case, but I mean, and sometimes I've just tried to order the MRI and then just try to fight the denial. And, but
right,
it's right. It's not efficient sometimes. Right. And
yeah,
it's
yeah.
frustrating for us as much as it is frustrating for patients. Right.
It's not efficient, but I'm curious to see if this may or may not change things for them. My
Right.
guess is probably not, but
Well, I hope. I mean,
yeah. I mean, I,
I
I
hear,
hate I hate to be pessimistic,
I know.
but
No, it's so easy to feel jaded sometimes in
yeah,
healthcare. It
yeah,
really is. I
yeah,
think I can, I try to, obviously you were in a teaching position as well, and I teach fellows, and I try to tell them, there's two sides of the story, right? The first side of it is we, the clinicians, see the patient, we know exactly what we think they need, and we want to order it, and we
yeah.
hate it when we get denials. On the other hand of the spectrum, I can see it from the insurance company standpoint of they're trying to avoid over ordering of certain things because these things are expensive. So,
Absolutely.
so, so I understand, I understand both sides of the point. So that, but so yeah, the answer is not easy, but I am optimistic. I'm hopeful that, with this crisis, we're able to come up with better policies, better algorithms, better ways to treat patients and actually get them the tests that they need without this waiting game or without this
Right.
sort of game that we do play. So yeah, I hear you, man. I'm jaded too sometimes, but
Yeah.
you know,
This is what I'll say. This is what I hope people will take out of this whole experience. I think 90% of people, of physicians, are going to find ways to focus on finding ways of how to monetize it.
okay,
Great. You know, um, I'm hoping that the people will the other 10%, I'll say, will be realizing that this is a very big opportunity to examine how our lives are tied to our jobs and our patients, and how telemedicine can somehow rebalance it in a way, so meaning that like maybe you could see an established patient at home from 9 to 9:30 while you're, taking care of your kids, that sort of thing. Turning to telemedicine was really what kind of opened up my eyes. I'm like, is there a different way to practice?
We need more outside the box thinking in medicine in general. This is how you disrupt things and make things better, make things more efficient.
Yeah,
Um,
absolutely.
and like you said, I mean, whether some people see this as just kind of a cash grab, a way to make money, or um, approach it in a more genuine manner, that's up to the individual person. But one thing's for sure, and I think you touched upon it, is it is allowing healthcare providers as well, or even patients at home sometimes to revisit sort of this work-life balance, right?
Mhm.
Perhaps in the future we will still be going to an office, but maybe 3 days a week, but maybe twice a week we can perhaps be at home engaging in some telemedicine and maybe spending more valuable time with family. Who knows? I mean, that's what I think. I think from any crisis, I think there's an opportunity for something kind of beautiful to come out of it. And
Yeah,
um, like I said, you're on the forefront of telemedicine, so you knew about this for years. We're all now finally opening our eyes to it and seeing the benefits. So, and I agree with you. I hope that people take this opportunity and genuinely introduce it into their practice in a very thoughtful manner and not a cash grab. I'm hoping.
absolutely.